Hello, everyone. Hello, welcome. Come on in. Thanks so much for taking time in your day to be here with us. My name is Amy Van Ness, and I'm going to be your host and discussion moderator today for this session. I'd like to begin by acknowledging the land on which McMaster University is located, which is the traditional territory of the Haudenosaunee and Anishinaabe nations, and within the lands protected by the Dish with One Spoon Wampum Belt. The wampum uses the symbolism of a dish to represent the territory and one spoon to represent the people who share the resources of the land and only take what they need. We seek a new relationship with the original peoples of this land, one based in honor and deep respect. May we be guided by love and right action as we transform our personal and institutional relationships with our Indigenous friends and neighbors. It's in the same spirit that I welcome all of you to the first of 3 town halls on moral injury and moral distress in healthcare providers during the COVID-19 pandemic. This work is supported by the Public Health Agency of Canada as part of their work to address PTSD and trauma in those most affected by COVID-19. Over the past 2.5 years, we've heard so much about the strain on the healthcare system and on the healthcare providers due to the pandemic. We owe a debt of gratitude to all of the physicians, nurses, therapists, personal support workers, and public safety personnel who, despite facing incredible challenges in their daily work lives, still found time and courage to talk to us and share their experiences. So this research project seeks to shine a light on the impact that the pandemic has had on the mental health of all those healthcare providers who have given so much of themselves to the service of others and continue to do so today. The evidence-based resources and tools we are offering to help build mental health literacy, supports, and resiliency are our healthcare salute, our way of saying thank you so much for your service. So one more thing, actually, before we get into the meat and potatoes of today's topic is I wanted to let you know that there will be time for our speakers to answer questions towards the end of the hour. So feel free to put them in the chat or use the Q&A function, and someone on our team will take note of them and we can address them later on. So to begin our program today, we're going to first watch a pre-recorded presentation by Kim Ritchie and Andrea D'Alessandro, both who join us live today as well. In the talk, they'll be diving into some findings from the recent research about moral injury in healthcare providers during the pandemic. I'm going to tell you a little bit about each of them before we go into the recording. So Dr. Kim Ritchie is a postdoctoral research fellow in the Department of Psychiatry and Behavioral Neurosciences here at McMaster. She holds a PhD in rehabilitation science from Queen's University and is a registered nurse with extensive clinical experience in mental health, geriatric mental health, and professional practice. As I mentioned before, Kim is involved in this research project meant to develop an understanding of the unique and shared lived experiences and psychological impacts among healthcare providers resulting from their work during the pandemic. This research will contribute toward the development of novel approaches to address the needs of healthcare providers and public safety personnel during and after the pandemic. Andrea D'Alessandro also joins us. Andrea is a graduate student of the neuroscience program, also here at McMaster. Her thesis focuses on respiratory therapists' mental health and experiences with moral injury during the pandemic. Beyond her thesis work, she's a core member of the COVID-19 related moral injury in healthcare workers and public safety personnel research team in the Trauma and Recovery Lab. I was joking with everybody earlier that the titles are a mouthful, so please forgive me if I am bungling any of them. Thank you both so much for contributing to the discussion today, and I think we're ready to take a peek at the recording.
Hi, thank you so much for the introduction. We're really pleased to give you a very brief overview of moral injury and moral distress today, along with some of our early research findings. As everyone knows, COVID-19 has impacted all of our lives in so many ways. And for healthcare providers, there have been additional impacts as they've really served the public in their healthcare over the past 2 years. Moral injury and moral distress have drawn increasing attention during the pandemic. Although there's not one unifying definition of these terms, they generally refer to being involved in or witnessing situations that transgress moral values. And although many moral challenges were present in healthcare providers' work prior to the pandemic, COVID-19 has introduced new situations that have really presented challenges for healthcare providers as they've really strived to continue providing the same high quality care while adapting to an ever-changing situation. And it's important here to also mention that not everyone who experiences these types of morally challenging situations will develop moral injury or moral distress. But for those who do, they tend to have a range of emotional, physiological, and cognitive impacts, such as feelings of shame, guilt, anger, PTSD, and or depression, disruptions in sleep, feelings of worthlessness or powerlessness, lost in trust of self or others, impairments in both work and at home, increased substance use, and increased risk of suicide. Since February 2021, we've been conducting interviews with healthcare providers from across Canada in order to understand the impact of COVID-19 on their mental health. And in our study, we asked healthcare providers to tell us about the types of situations they faced during the pandemic that really have transgressed or challenged their moral values and beliefs. We'll briefly share a few of these findings with you today, along with a quote from the healthcare providers. Throughout the pandemic, and in particular during lockdown periods, many hospitals had policies that restricted visitors from coming to the hospital. And although these policies were intended to protect patients and staff from infection, many of our participants perceived that these policies were a violation of their moral values of having family members present at end of life, and that believed that some exceptions should be made in these circumstances. And because family couldn't be there, many healthcare providers stepped in and they replaced family at end of life, holding the hand of these patients. And this was also very emotionally difficult for healthcare providers to take on this role. Healthcare providers also told us, and many of these in critical care units, they said that morally challenging situations were ones that involved decisions around resuscitation or prolonged ventilation. And in these situations, healthcare providers told us that they felt the care that they were actually delivering was denying the patient a peaceful and dignified death. Also, many healthcare providers told us that they experienced drastic increases in their workload, and this was across multiple care settings during the pandemic, and even more so during times when community transmission of COVID was high, resulting in increased hospital admissions. And the moral challenges in this situation occurred when patients suffered harm from healthcare providers' inability to what they perceived was inadequate care or stresses on care from high workload and low staffing. We were also told about multiple instances of bullying, harassment by healthcare providers from colleagues or even leadership. And this really left them feeling incompetent and demoralized. We were also told about an increase in violence coming from patients, visitors, and families. And this was mostly during times when there was visitor restrictions or changes in the patient's care. And the last area we'll cover today that many healthcare providers talked about the moral challenges related to decisions made by healthcare organizations. And they felt that some of these decisions may have negatively impacted patient care when it came to bed or even equipment allocation. And healthcare providers in these situations perceived a disconnect between the values of management and hospital leadership and those of frontline healthcare providers. And this resulted in feelings of betrayal. Now I'll turn it over to Andrea, who will share some of our other results.
Thank you, Kim. So in addition to interviewing healthcare workers throughout 2021, we also asked Canadian healthcare workers to complete an anonymous survey online. And on this slide here, I'm showing you some of our data of a subset of our healthcare workers, so among respiratory therapists. And we wanted to understand if respiratory therapists were considering leaving their positions during the COVID-19 pandemic. And what we found was in the spring of 2021, 1 in 4 of the respiratory therapists that we surveyed were considering leaving their position due to moral distress. Interestingly, those who were considering leaving were characterized by greater adverse psychological outcomes. So those considering leaving scored significantly higher in terms of symptoms of depression, anxiety, moral distress, and PTSD. Interestingly, when we ran predictive models to understand factors that may increase someone's likelihood of considering leaving, we learned that having considered leaving a position in the past and endorsing system-related sources of moral distress, so that's distress coming from organizational factors like low staffing or low resources, Along with PTSD symptoms, these three predictors actually increase the odds of current consideration to leave. But what this analysis also revealed was that the contribution of the mental health variables in predicting intention to leave was very, very low. And actually, past consideration was the driving factor in terms of if a respiratory therapist was currently considering leaving. So these results tell us that although the respiratory therapists who were considering leaving may be in need of even further psychological support than their colleagues who were not considering leaving, this tells us that we perhaps need to look outside of the individual level to understand why respiratory therapists were considering leaving. We need to look to organizational factors, those factors that may have been consistent between considering leaving in the past and also at the time of our data collection. And so this work among respiratory therapists will be replicated among a broader sample of healthcare workers to better understand the extent of turnover expected and to understand those factors related to turnover. And this will be very timely work because the preliminary results that we've gathered in the latter half of 2021 tell us that almost half of the 216 healthcare workers that we surveyed were considering leaving their positions. So as our results indicate the potential role that an organization may play in assisting their healthcare workers in terms of their mental health and in retaining these healthcare workers, we wanted to better understand healthcare workers' perspectives on how their organizations and leaders can best support them. And so in our interviews, healthcare workers made many recommendations for how their organizations and leaders can support them. So firstly, healthcare workers want to be listened to and validated. Healthcare workers want their leaders to know about their experiences during the pandemic and the impact that the pandemic has had on them and on their families as well. Now, this could include arranging reflective listening sessions, asking questions to really understand the impacts, and then validating healthcare workers' experiences. Healthcare workers know that their leaders don't have quick fixes for many of the complex problems that they faced during the pandemic, but they need to be supported by being heard, valued, and understood. Secondly, our healthcare workers want to be questioned about what they're needed. Healthcare workers are aware that they have stressful jobs and they want supports to be able to perform those jobs well. And during our interviews, healthcare workers told us that having access to long-term mental health supports was one of the most important tools that they believed could improve their mental health. And importantly, these supports need to be informed about their role as a healthcare worker to understand the types of challenges that may be unique to their line of work. And finally, it's important that healthcare workers are acknowledged in terms of their inherent occupational moral stressors that they face daily and especially during the pandemic. Difficult ethical situations are part of most healthcare occupations and can't always be removed from the job, but providing healthcare workers with adequate training for these situations will be important to prepare our healthcare workers. When morally or ethically challenging situations arise, discussing them in an open way within teams will promote awareness and connection among team members and remind them that they're not alone. Now, this list is by no means exhaustive, and further recommendations can be found in our moral injury infographic. So altogether, our research shows that healthcare workers have indeed faced a range of moral challenges related to their occupation during the pandemic. And most of these events that have been described really centered around situations that involved a risk or potential risk to harm to a patient. And this may indeed be the moral value that's transgressed for healthcare workers in these situations. Further research is needed to identify interventions for moral injury and distress and to understand the long-term impacts, both psychological and in terms of leaving one's profession. Our research team is dedicated to continuing this research, and we will continue to advocate for our vital healthcare workers. With that, I'd like to thank you for your time today and also thank all of the healthcare workers who participated in our study so far. We thank you for your service on the front lines of the pandemic. Thank you.
Thank you for sharing your research, Kim and Andrea. I really appreciate adding your perspective from what you've learned to this discussion today. I'm approaching today's topic of moral injury from a learner's perspective. I'm not a doctor, and the topic is relatively new to me. So as a member of the public living through the pandemic, it's hard to grasp just how much healthcare providers have given themselves to the care of our loved ones during the pandemic. So I just in this moment, I'm finding myself overwhelmed with this feeling of intense gratitude. So if you're in the audience and you're on the front lines, just thank you so much for your service. So we're going to move into the live discussion portion of our event today. This is a chance to get into the nitty-gritty and understand the complexities and nuances of moral injury through the lens of work during the pandemic. I'd like to welcome Margaret McKinnon, Alex Heber, Kim Ritchie, and Andrea D'Alessandro. I was hoping each of you could take a moment to introduce yourselves and tell us a little about your involvement in the project. And I was thinking, Margaret, maybe we could start with you.
Much, Amy. And again, I just want to echo your comments. This project is deliberately called Healthcare Salute. Thank you for your service. And we are so appreciative to healthcare workers across the country for the sacrifices that they and their families have made over the pandemic. We recognize they have been tremendous. My name is Margaret McKinnon. I'm the Homewood Chair in Mental Health and Trauma and a professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. I'm also a clinical psychologist, and I serve as the research lead for the Mental Health and Addictions research program at St. Joseph's Healthcare Hamilton. And I'm a senior scientist at Homewood Research Institute. And I've had the privilege of being on the ICU units and COVID units over the course of the pandemic to provide mental health supports. And really much of that, what we saw on those units was a motivation for this work, to see the suffering of healthcare workers and also really wanting to help in these difficult situations.
Alex, would you like to go next?
Sure, thanks, Amy. So my name is Alexandra Heber, and I am currently the Executive Director of the Canadian Institutes for Pandemic Health Education and Response, which is a knowledge hub that we're creating to host and kind of bring together the information from a number of projects that have been funded by the Public Health Agency of Canada, as Amy described at the beginning. So I'm doing that work, and this is one of those projects. I'm also currently on secondment for my regular job, which is Chief Psychiatrist of Veterans Affairs Canada. And I'm also a veteran of the Canadian Armed Forces and an associate professor at McMaster University. So I'm very, very honored to be here today.
Thank you both so much for being here. And Kim, did you want to add a little bit of context to, I know I introduced you, but it's your time to introduce yourself.
Thank you so much, Amy. And yes, so my name is Kim Ritchie, and I've also had the pleasure of being part of this project, and it's really been such a privilege. And I work at as a research associate in the Trauma and Recovery Lab at McMaster University. And we really started this project, I guess it's over a year ago. It's been just a wonderful journey of throughout the pandemic, and we've really felt it as part of our role, part of our service towards the pandemic, to try to capture the stories of healthcare providers and to try to understand and to advocate for them throughout the pandemic and what they have been going through, and ultimately to thank them for their service and to let them know we hear you. And we really just want to give you a lot of gratitude for what they've done and the stories that we've heard throughout.
Thank you, Kim, for being here. And Andrea, would you like to introduce yourself?
Yes, thank you, Amy. My name is Andrea D'Alessandro, and I'm a graduate student, one of Margaret's students at McMaster. I'll be starting in the research and clinical training stream this fall, my PhD. And I've had the privilege to work with this wonderful team, Alex, Margaret, Kim, and the rest of our amazing colleagues. And echoing what my colleagues have said today, it really has been a privilege to be a part of this meaningful work and to get to know healthcare workers on the front lines, to hear their stories, and to be able to amplify their voices so we can ensure that they're well supported. And again, it really just is a huge thank you to our healthcare workers.
Wonderful. Well, thank you all for being here. I'm really excited to sort of get into the nuance and complexity of this topic, because I know you all have just like a wealth of knowledge to share with our audience today. I'd love to start the conversation by defining moral injury, sort of to situate it within the context of this project. So Dr. Heber, I was wondering if you could start us off by helping define what moral injury is and where it comes from.
Sure, thanks, Amy. And this is really going to be to add what Kim and Andrea have already explained in their previous remarks. And I'm going to, again, try and put it in a context, in a bit of a historical context. This was a term that was actually first developed by those who were looking after soldiers who were returning from war zones and combat zones. So the term itself was first used actually by those who were helping veterans from the Vietnam War. So it's been around for a long time. And basically, it was used to describe what soldiers were suffering from who found themselves involved in situations that contravened their own moral codes or ethical beliefs. So in addition to any other traumatic situations they may have found, that there was something that was still haunting these folks when they returned from war. And it was often to do with either they witnessed situations or were within situations where they felt either they were powerless to intervene or they couldn't help when somebody else was injured or killed, or they saw abuse of other people in the war zone. And sometimes it also involved feelings of betrayal by their chain of command or leadership. And the most striking thing about it is that these were feelings that really stayed with the person and haunted them. An example is to think about for those of you who know anything about the story of General Romeo Dallaire, who still suffers from moral injury after his experiences of leadership in the 1990s in Rwanda, where he was powerless to stop the slaughter of thousands of the residents there. So he still talks about this moral injury that he suffers from. So now what we're seeing these same kinds of reactions in healthcare workers who served on the front lines of COVID-19, often struggling with feelings of having been powerless, feeling very distressed that they weren't able to provide for their patients what they felt they wanted to, and for a number of reasons, often because the overwhelming number of patients, how ill the patients were, as well as that there just weren't enough of them. And again, with them, that moral distress and moral injury also often takes the form of feelings of anger and betrayal towards their own leadership, who they feel let them down, or to their institutions. And I think Margaret is going to, because of her work really on the front lines, providing support to many of these healthcare workers, she's going to talk a little bit about specific examples.
Thank you so much, Alex. And, right from the very beginning of this pandemic, it's been clear that healthcare workers are essentially on war footing. And we recognize that the levels of distress that many are experiencing are very similar to what our military members see in the combat theater. That's been really an evocative understanding of how difficult some of these situations have been. We have heard, for example, situations where, due to a shortage of personal protective equipment, some healthcare workers were asked to wear their masks for 2 weeks and then turn them over when they became dirty. And you can imagine when you're risking the safety of yourself, and for many healthcare workers, even more critically, the safety of their families, to come to work. Many felt that they weren't receiving the support or the duty of care that institution had to them. And these have been really difficult stories to hear, but even more so to experience for those on the front line. We also know that, as Kim had mentioned, many healthcare workers were put in that role of family, becoming essentially family members for patients on the units. And so there were things that we had to do throughout the pandemic to protect the safety and the security of the healthcare system and for the greater good, but these were incredibly difficult things. And some of them did not feel morally right to our healthcare workers. And a good example of that would be, for example, having to turn away the parents of a dying child, because at that early point in the pandemic, parents and visitors were not allowed into the room. And we certainly heard about these situations. We know also, during the time I spent on the front lines and also from the stories we've heard, often healthcare workers perceive the care that was being offered as being futile. And in some cases it was, right? And healthcare workers were caught in that difficult position between families who understandably want to hold on to hope for their loved ones and providing care that is invasive and sometimes painful, where, for example, it would take 7 people to prone or turn over an elderly individual in an attempt to help with their COVID illness. And so these were really difficult situations for healthcare. And in some cases, healthcare workers really communicated to us that they felt a bit it was like torture. And that is a very evocative term. It's one that's hard to hear, but it is the experience of healthcare workers, and they're left with this lingering distress. And in particular, we found moral distress or moral injury surrounding some of these situations.
Thank you for that context, Margaret, and for the really concrete examples of what it was like in the units. So Alex, I guess my follow-up question is, from a clinical perspective, how can healthcare workers know if they're experiencing moral injury? And then I was also hoping, Kim, I'd love to learn more about what you found in your research about this as well.
Sure, so let me begin. I think really some of the things that people feel are what we've been describing. So often they will, after a situation, you know, most of us, when we go through a traumatic or difficult situation, we will have a few days, sometimes up to a few weeks, where we're still very distressed by that situation. We may have nightmares, we may have difficulty sleeping, we may find that we are reminded the situation is popping back into our heads at you know, strange times. But generally, within a few weeks to a couple of months, that fades into the background for most people. But for some people, a lot of those experiences and the feelings that went along with them, they just don't fade and they linger on. And so for especially people who, again, have felt they were in these morally compromising situations where it did not fit with their own ethical and moral beliefs and standards, they are left struggling with that. And it's in a way, we can compare it to like an unresolved grief reaction, where people just can't get over it, and they continue to think about it, and they're often feeling guilty for things they had no control over. Okay, and then there's that other situation where they had faith that those they report to, that their leadership would be there in these times to help out and take care and make sure that they were protected. But what happens instead is they feel abandoned. So that's another strong part of moral injury. And again, usually when people have these feelings at first that then fade, we call it more moral distress. But when those feelings last and they just can't seem to get over them, then we'll call them moral injury. Sometimes what can be helpful for people is, again, if they have trusted colleagues, a good team of people, that can be helpful to them. We created a project right at the beginning of COVID-19 for frontline workers. And it was really at that time, how are we going to help these people remain okay and ready to work and not suffering from some of these after effects? And it was really interesting because when we went and asked them what were the most important things for them to feel they'd be able to cope through COVID and all these changes that were occurring, the number one thing we were told was that I feel my leader has my back. And so I think that's why we're coming back to that idea of part of moral injury is that betrayal that people end up feeling. And this was right at the beginning of COVID that they were telling us that. So again, even now, a couple of years later, for leaders to be there, to step up, to support their people, we know can be helpful for them. I'm going to pass it over to Kim, though, because I think she's got a lot of good examples to add to this.
Thanks so much, Alex. That was fantastic. And, you know, we've heard a lot of, in our interviews, exactly what Alex was describing. And a lot of healthcare providers have talked about this ruminating over what they have had to do, or maybe what they've seen, or what they were what type of situation they've been in. And that rumination just doesn't seem to go away and becomes to the point where it's overwhelming and the emotional impact comes with it. And we've heard a lot about healthcare providers feeling very angry as well. And going back to what Alex mentioned about anger towards the system, towards leadership, towards just COVID in general, and the types of situations they've been faced with, and feeling very let down by the healthcare system as a whole. And keeping in mind that, you know, prior to the pandemic, healthcare providers were very used to making very difficult and challenging and morally challenging decisions. But this is different. And there's a new added layer on top of what was already challenging in a challenging situation, under resource situation. And it's just that those situations have become worse. And we often use the word amplified, as healthcare providers told us it's just made what was there already even worse than it is, or than it was before. And so I think the how they know, I think the other thing that we've heard a lot about is just a sense of negative self-talk, negative beliefs about yourself, where you might say to yourself, you know, I'm a bad nurse, or I'm a bad physician because of what I've done or what I've seen. And it's trying to, you know, understand that it's a situation that you're placed in, and trying to recognize that that's part of the talk. And the only other thing I'll just add to Alex's comments, the other thing we've heard from healthcare providers is they feel like they're living in two worlds.
Mm-hmm.
And, you know, they go to work and they're in, essentially, as Margaret said, almost a war zone. It's completely different. And then they come home and they're trying to function in these two worlds. And so we hear a lot about these disruption in function where they feel they can no longer parent, or they can no longer be a spouse, or the family member they weren't before. And it really shakes your sense of self and trying to navigate back and forth between these two worlds that are so drastically different, and you don't have a way to kind of reconcile them.
Yeah, yeah. And so Kim, what and maybe Andrea as well, I'd love to hear your perspective on what have you found that healthcare workers are saying is helpful once they've sort of acknowledged that this is the way they're feeling?
Yeah, I think, you know, healthcare providers, they have a very strong sense of caring for others, and they want to serve others, and they prioritize the needs of their the people they care for, the families and the patients they care for. And especially during the pandemic, as we said, you know, they were living in this world that was so different, and working days and hours and weeks on end without breaks, without vacation, and many more hours than they may have before. And so I think one of the first thing is this sense of self-compassion. We talk a lot about self-compassion in our work. And self-compassion is a term that has been around for many years, and it's now being applied to healthcare workers more and more as we're starting to realize this sense of serving others, and how we have to be able to understand that we have to prioritize your own needs too. And self-compassion is a term about being compassionate towards yourself the same way you would be towards someone else, and giving yourself that sense of empathy and humanity that you would to your patients or your families or your friends or your families. So I think that's one of the first things. And then I think the other thing is that many times during the interviews, healthcare providers said that when they completed some of our surveys on moral injury, that's when they first understood what they were feeling, and it gave them a way to understand it. And so I think, you know, as we become more familiar with the term of moral injury, we talk about it in our healthcare organizations, and amongst our leadership, then I think it gives a way to frame what the experience is. And I think that's really helpful. It gives us a way to understand what you're feeling. And healthcare workers have said that that's really helpful for them. And I'll turn it over to Andrea, because I know she has lots to share too.
Yes, thank you, Kim. I think you said that so well, really giving yourself permission as a healthcare worker to take care of yourself. It's so easy to be focused on caring for others. That's part of the heart and the humanity for a lot of our healthcare workers. That's why they got into the field. But in these times of recognizing when you may be in moral distress, experiencing a moral injury, recognizing that you need to take care of yourself. And in doing that, something we've heard a lot about from our healthcare workers in our interviews was about coping strategies or just self-care strategies. And not surprisingly, a lot of healthcare workers found this very difficult to do during the pandemic. As Kim mentioned, healthcare workers are often working through stressful situations in their field. That's not new. But what was new in this time was the barriers to maybe someone typically would go to the gym or would go out for social time with friends. But with lockdown periods, that wasn't possible in many cases. Additionally, with the added stress and the amplified nature of the stress during the pandemic, a lot of our healthcare workers said that they couldn't even find the bandwidth or the energy to take care of themselves like perhaps they had done prior to the pandemic. And so with this, we really see in these conversations the need for to help our healthcare workers create a plan, say, what can I do? What can I turn to? Who can I call? How can I check in with myself? I know that in our group and in our project, we're developing tools using such as the mental health continuum. So allowing healthcare workers to read of common signs of different levels of stress, see where they fit in, and providing them with supports that would work best for them to be able to get the help that they need. So I think there's many tools, and we'll continue to work to make those readily available for our healthcare workers.
Wonderful. Thank you both for. Oh yeah, Alex, go ahead.
Sorry, I'm just reading some of the comments. It made me think of a few more things to add, if you don't mind.
Yeah.
So, and one of the things I think Kim had mentioned this certainly when we were talking earlier is acknowledgement. So just first of all, I think the fact that we are acknowledging this and we are now looking at it and saying this exists. There is an issue here for healthcare workers, and it's for good reason that they're feeling this way. So that acknowledgement, I think, is the first step to people starting to feel better and to also get help with how they're feeling. Reframing, or as Kim mentioned, self-compassion, that's really important. I mean, why do people suffer from moral injury? It's because they are people who care. Right? That's why they're struggling with these things. These are people who care so much about other people, and that is a good thing. It's not good when you suffer, but they're basically very, very good people. Then the other, and this was commented on a few times in the chat, having supportive and present leadership. That your leaders are there with you, telling you you're doing a good job and supporting you when things don't go well. That's so incredibly important for people. And then social support, having people who are able to work in teams that get to know each other, that can support each other is very, again, that's certainly, it's a way to help prevent some of this from happening. And I know in healthcare that often that just wasn't possible. And I think that because of sometimes the fracturing of that ability to be working in a consistent team over time, that's also contributed to these problems. And then of course, for some people, sometimes getting some professional help, some support, some guidance, some counseling, I think can be very, very helpful.
Yeah, oh yeah, Margaret, go ahead.
Thank you so much. One thing I just wanted to comment on is that this is happening for our frontline and it's happening for our leaders too. And so just to acknowledge the pain and suffering as well of leaders who are often put in difficult situations, having to make truly impossible choices. And so we want to acknowledge the suffering of everyone, recognizing that moral distress and moral injury has been a big part of the picture for our leaders too. And I often think of healthcare as a family. And I think one of the big challenges we're facing right now is how do we put our family back together again?
Yeah, absolutely. And I think that that's like sort of the perfect segue to zoom out for a moment and talk about the healthcare system in general, because self-care and compassion for yourself as a healthcare worker is of course important, but also you need to be working with it as a supportive system, I think, to really truly thrive in the environment you've chosen to work in. So when I've actually seen this in the comments as well. I think Stephen commented that, all these factors that we're discussing today were important pre-pandemic, but they're essential now. So I'm wondering, Margaret, what do you think these stressors like turnover, short staffing, effects of moral injury, what does this mean for the healthcare industry moving forward?
Yeah, no, thank you. And I think part of the moral distress that is arising right now is around our inability, in some cases, to provide adequate care. So we know that many units are running short-staffed right now. We're seeing that many people who are very junior to the field are being put in positions that would typically be reserved for more senior healthcare workers. And if we think about the continuity of our healthcare system, we know that when we did our initial survey of all healthcare workers, so all professions across Canada, we saw during the Delta wave that about one in 4 were considering leaving their clinical position. When we repeated this survey during Omicron, what we found was in fact 1 in 2 healthcare workers were considering leaving their positions. Past evidence suggests that among those who consider leaving their positions, about 1/3 did leave. And we cannot afford at this point to lose any of our healthcare workers, let alone those who are experiencing this moral distress and this moral injury right now, that from Andrea's work and other work and Kim's work showing that this is really driving a lot of what is making people consider leaving their profession. So I think addressing, as Alex was saying, speaking about giving people words for their experiences, providing supports. It's a way of helping individual healthcare workers and leaders, but it's also a way of ensuring this continuity, essentially, of our healthcare system, which really is in a perilous situation right now. And again, it's why we want to say, we're so grateful to everyone who served. We understand for those who left positions because this was incredible suffering. And we really want to support those who remain on the front line in leadership positions because they are such a precious resource to Canada.
Yeah. Oh, excuse me. Absolutely. So that in your presentation earlier, Kim, we heard a bit about from healthcare workers about how their employers can support them. I'm wondering what other strategies healthcare providers suggested could be done at that organizational level to support them.
Yeah, thank you. I think, just adding on to the comments that Margaret made and even Alex made earlier, we've heard from healthcare providers that many of them really do want to get supports, mental health supports. They understand that their job is stressful and normally, and they understand that during COVID, it's, just become so much more stressful. And they find that there's so many barriers in place of getting the types of supports that they need. And so I think, that's one thing that, that would be really important to look at is how do we get really accessible supports that can get through some of these barriers. Some of the barriers we've heard about is that healthcare providers, especially those who work part-time or casual, don't have a lot of benefits, or they don't have a lot of ability to get these types of healthcare support. So they want them to be accessible for them and available. The other thing we've heard about is that they really want these types of supports that they get to be tailored. And so, and by that, what we've asked healthcare providers, all of the ones we've interviewed, we've asked them, what is the most important thing for you to get mental health support? If you were to get mental health support, what would be the most important part of that? And almost everybody has said, you have to know the type of work I do and the types of situations that I've been in during the pandemic. And so I think that's an added component in terms of mental health supports, that we have to also educate those who provide mental health support to understand these things about COVID and about the type of work in order for healthcare providers to feel that they're heard and understood and not having to repeat things, that over and over. And then the last thing is having long-term mental health supports. I think, part of the thing I've really learned during this is that there is a need for long-term support for many healthcare providers because of the stressful nature of their jobs. And and many healthcare providers have said, you know, I want that. I want to be able to do my job better, or not, I guess not so much better, but to be able to also manage my stress and the types of mental health strain that the work causes, even outside of the pandemic. And I think we really, as a healthcare system, have to look at that now too. How can we better support our healthcare providers in mental health?
Absolutely. Thank you. I'm so sorry. I have like a fire alarm going off in the background. I don't know if you can hear it. Can you?
Okay.
I'm so sorry. I don't know what's happening. I'm just going to keep moving here, but I'm really apologize if it's loud. I think that's a perfect observation and note, Kim, to end this fireside chat on. Oh, Margaret's got something. Go for it.
Thank you. I just wanted to add, with respect to mental health supports for healthcare workers, one thing in the St. Joseph's healthcare system in Hamilton and at St. Mary's in Waterloo and also at Homewood Health, we've been providing on-unit supports to healthcare workers. And I think this is really important. So, you know, during the time when the first time I was on a COVID unit, I was actually in the storage closet. So I had about 36 hours at the hospital, much of which was spent in the closet on the unit. And when nurses and staff came in to change their masks, that was the only time that they had for mental health supports. And, you know, that's no fault of an organization. It's just the way that it was. Things are so hectic. And there's really no substitute for sitting down at a nursing station, being present, allowing people to come to speak to you. One of the most powerful things that we could say, as Kim was mentioning, was, I recognize that you're living in a different world right now than people who are not involved in healthcare. And that your experience is very different when you go home. It may be hard to talk about. Others can't appreciate or understand the circumstances that you face. And I think for our healthcare workers, many don't have time to go to the library or to go to other parts of the hospital. We need to be with them and present on the units to provide those supports. And I think that's a really important thing that we've learned in Hamilton and Guelph on surrounding supports for healthcare workers.
Yeah, absolutely. And I think that is also the perfect segue into this Q&A session, because I see that we have some questions from healthcare workers themselves that we're going to address today. So that's kind of it for me. I'm going to pass it to Teresa, but I wanted to thank you all so much for chatting with me and helping me learn about moral injury today. And I will pass it to you, Teresa.
All right. Well, thank you very much, Amy, for your time and excellent skills. I'm going to have to recruit you to be a podcast or a webinar host. You've got some superpowers there. But Amy, I'll keep you on the stage for now to just round out the number of people here. But I think this is the first one would be if everyone could maybe share in the chat and also out loud, where is a great place that we can learn more about your research and the data that's been presented here? That is I would say not a hardball question, so we're going to go with that one first.
Sure, I could start maybe if that's all right. So through our funding from the Public Health Agency of Canada, we are mounting a website called Healthcare Workers Salute. Thank you for your service. And this will be information available in both French and English about the research study, about resources for healthcare workers. We'll be providing more education around moral injury, post-traumatic stress injuries. We'll also have a trauma-informed training course for people who wish to support healthcare workers or for healthcare workers themselves. We're going to be working to enhance cultural sensitivity around these issues. So really seeking to understand the experiences of healthcare workers through their own words. So we'll have video recordings of healthcare workers speaking about their experiences, and then in-depth reflection exercises for those who are watching the videos to relate it to their own experiences, to teach about terms in very plain language, because we recognize that a healthcare worker at 5 o'clock or 3 o'clock in the morning may be Googling moral injury, COVID-19 pandemic, and we don't want a long description. What we want is something that's accessible and easy to use. And so this website will provide a lot of information about this. We've also been publishing our work, and we could send out links to that work as well. And finally, we did prepare a briefing note for the Canadian government that summarizes these findings. And what we'll be able to do is also share that with participants, with also some recommendations surrounding these findings.
Well, that's very exciting. I think the website's going to be huge, and do let us know, and I'll help boost it and or promote it with my social media presence. Alex, please go ahead.
Yeah, and so just to add to that, as I mentioned earlier, I'm going to be creating also a web presence that is going to host as well and link to many of these, what's being created in this project, as well as a number of other projects that have been funded by Public Health Agency of Canada. And just our website is not up yet. It's probably going to be about another month, but it will have this whole host of resources as well. And the name of it is, the easiest way is to remember the acronym, which is CIPHER, CIPHER, will be the acronym for that website, and we will link to all of Margaret's resources as well.
Excellent. This is great. I'm going to move on to the next question. So an anonymous attendee asks, you noted that participants needed to feel their leaders had their back. What is the impact of leaders working from home and not being visible alongside their frontline staff? I found that staff feel resentful and more disconnected from leadership, especially higher level leadership, because the leaders are working from home. Any thoughts on that dilemma? Maybe I'll go to Andrea. She was nodding.
Yes, I think what was said in that comment is exactly what we heard from healthcare workers in our interviews, that was a key source of some of that betrayal, that side of moral injury, where a lot of workers on the front lines, respiratory therapists, physicians, nurses, they're telling us that they have certain needs and experiences, yet decisions are coming from higher up, from people who aren't there. They're not seeing exactly what they're seeing. They're not made fully aware of the concerns and maybe why a certain policy or procedure doesn't make any sense, or is elevating stress or putting the workers at further risk. And so I think that comes back to what we were discussing earlier about the need to listen to the healthcare workers, organizations, leaders. They need to simply ask, what can I do to support you? How can I help you? And facilitate those discussions about creating a space for the frontline workers to share their concerns, to have the time to question these different policies, procedures coming up that maybe they disagree with.
If I could comment a bit further on that, Andrew, thank you for that great answer. We know that the risks of COVID-19 were not evenly distributed, and that's a really important thing for organizations and individuals to acknowledge. There were those who served at the very front line who took on the greatest risks for their families and for themselves. And that's an important piece that we can acknowledge. We also know that for people who were at home, many of them also suffered in the sense that they felt so guilty that they weren't there. And so again, when we talk about putting our family back together again, I think there's some of the things that we just need to have in the open to talk about and help us to come back together.
I think there's a lot of stress of trying to manage things when you can't see, right? And I do think that that's a challenge. And I think that a lot of people probably had some moral injury, even, just doing it from a Zoom, knowing that they'd want to get in there, but that's probably not the best place for them. So that disconnect can be really hard. And even as you point out, that sharing of those perspectives would be important. All right, we have a couple more minutes. I'm going to ask one more question. And this one comes from an ICU nurse, Annie, who has been for the past 14 years an ICU nurse, and then she's transitioned into being an RN psychotherapist. She finds that a lot of the coworkers prefer the support of other coworkers, like more of a grassroots, because like someone that's at your elbow, that understands you, that has been going through that, versus a third party. I think this probably goes along with the lack of trust and fractured faith in individuals who don't have the same similar lived experience. What are your thoughts on this, and how do we, as bedside nurses or leaders, better support these kind of programs for healthcare practitioners and professionals? Thank you very much, she says. All right, we're going to go to Alex. Go for it.
Yeah, let me start out with that one. So first of all, I think that is such an important issue. And Margaret and I think Kim kind of touched on this earlier, that whole issue of what we call cultural competency, that when therapists, when helpers are trying to help somebody in a particular profession, it's really important that they have some sense of what that person's work life and home life that is affected by the work life, what that's all about. We really found that, again, if I go back to my military experience, that was really critical, that we had people working with our folks who really understood what it was like to be in the military. And so I think for healthcare workers, this has become more and more of an issue, especially with the crisis occurring. So yes, cultural competency. And again, Margaret mentioned that one of the parts of this project is going to be to create some resources for therapists to help them become more culturally competent in the world of healthcare workers.
All right, excellent. Very snappy. I love it. All of you should be on talk shows more often. So I love it. And I think that there's just a lot out there right now that we need to digest. And it sounds like there is an upcoming webinar, webinar number 2, that all of you are invited back to come and interact with us more. And so please watch out for that advertising for Healthcare Salute Town Hall number 2. September 15th, you can mark it in your calendar, 10 to 11 a.m., family and interpersonal impacts. That's going to be really important. So please, please, please jump on in. That one might be a good one to bring a family member or others who have been your supports, because I think we need to salute all of them as well. And I think that this has been fantastic. We're going to go to Margaret for some closing remarks, and then maybe I will also ask Andrea, you have a slide with some information that you're going to share as well. So if you want to pop that up.
I know. I really just wanted to conclude by saying thank you again to those who serve. We really want to also acknowledge that what happened over the past 2.5 years has also occurred within a unique historical context where we've learned about residential school issues surrounding residential schools and the discovery of the bodies of innocent children. We've had the murder of George Floyd, and there's been a historic context that also surrounds this. And recognizing that for many healthcare workers from equity deserving groups, went to work was not only the burden of the pandemic, but also the current social context. And we want to really acknowledge that. And we will be talking about that more as we go forward with this work. We want to also thank our funders who helped us to do this research. So both the Atlas Institute, which was formerly known as the Center for Excellence on PTSD, Homewood Health, who made an incredibly generous donation to Homewood Research Institute. CHR has been a big supporter. And finally, the Public Health Agency of Canada for their support to move this work forward. And we just want to thank all of you for your service. That word is really meaningful to us here. We've worked with the Canadian military. We've had the privilege of working with the Canadian military, with veterans, with public safety personnel who have also served selflessly throughout this pandemic. And the word service means something to us. We just want to thank you for that service that you've given, both you and your families throughout this pandemic. So thank you.
And thank you so much to all of you for spending the time with us today. I'm just going to give a shout out again here to all of you for the great work that you're doing. And I'm hoping that people in the audience will feel their gratitude as well and express it and participating in your research, actually. So for all of you who may not know what that little squiggle thing in the corner is, probably you do know by now, but you can take your phone, open up the camera, and you should just put that in the middle of the shot, and it should actually open a hyperlink to be able to go ahead and participate in this. We've also put a bunch of other information about how you can actually give us feedback about today. I'm going to pop that in the link as well, the link in the chat as well. And we're really excited to have all of you join us. And the webinar has been recorded. There'll be some post-production, and then we'll be putting it on the websites that everyone is making, and it'll be shareable on YouTube. So we're just really excited to have all of you engage in this way. So thank you so much for all your time.
Thank you, Teresa. And we will provide also simultaneous French translation on the recording as well for anyone who would like to watch this video in French. That will be available as well. Thank you, Teresa, so much for your support. And Amy, thank you to our wonderful host. Thank you so much. It's really great.
Thank you for having me. Thank you for having me.
All right, and the pre-registration, someone has asked, is not available yet, but just hold the time and your date, and then keep an eye out for our social media. I'm sure you won't miss it, and we'll be in touch.